All right. Hi, everybody. Welcome to the Tenacity Project Doc Talk, the first in a series we're going to do this year in 2024. For anybody who doesn't know me, my name's Teresa Sherry. I'm the founder of the Tenacity Project. We're a nonprofit organization, women-led, um, working on female empowerment through the sport of lacrosse. And we're wanting to provide today some expertise from one of the parents in our organization and his colleague. We do see a lot of these injuries in current and former players who have come through our program. I've had several phone calls this year, tough phone calls about these ACL injuries, and we're really excited to have these guys here talking about some different things around prevention and also in the case that something does happen, what we can uh, do to recover. I think whole person development is really important to us. I played soccer and lacrosse at Princeton and went on to coach. I've been lucky enough to do that for the last almost 20 years. And it's really important for all of our girls and young women to develop mind and body. And so I think this is part of our initiative to provide tools for that. And each girl can then find what fits for them as far as their day-to-day routine, annual routine. And we hope that you enjoy this chat. So I'll first kick it over to Chris to say hi and introduce himself, and then we'll go to Mark.
Yeah, my name's Chris Donaldson. My daughter Anna is a 27 with the Tenacity team. I am an orthopedic surgeon, trained at the University of Maryland for my orthopedic residency, and then went on to Ohio State where I did my sports fellowship. I am currently a partner and partners with Mark Sando at the Orthopedic Medical Group of Tampa Bay. And so Mark is our lower extremity sports specialist who trained at the prestigious Kerlan Jobe Sports Fellowship. So Mark has a wealth of knowledge about ACL injuries. He's really a regional and national expert when it comes to this, and does biologic augmentation ACL reconstruction. And so I thought it was a really great opportunity, given the fact that we're in the middle of some of our season and looking towards an early summer season coming up, that we would talk about maybe ACL myths, prevention, augmentation strategies. And so I'll pitch it over to Mark and he can kind of go from there.
Great. Well, thanks so much, Chris, and thanks, Teresa, for having me tonight. I'm excited to talk about this. This is a topic I really enjoy. ACL injuries are a very common injury. So I wanted to talk to you guys about that tonight, about the injuries themselves. What are some strategies we can use to help prevent them? What are some specific things we need to think about in the female athlete specifically, which is important for this group? And then if we do end up with an ACL injury, unfortunately, what do we do about that? And I want to alleviate a lot of fears that is a bad injury, but is an injury that can really be taken care of and is not a career-ending thing. So let's get started here. Just make sure we're working. All right. So ACL injuries, they account for about half of all knee injuries that occur. There's over 80,000 a year in the United States, with most of them being in the 15 to 25-year-old athlete population. There's over 400,000 ACL reconstructions done in the U.S. every year. Unfortunately, this injury is more common in females than males, up to 4.5 times as common in female athletes versus male athletes. And we'll get into some reasons for that later. ACL injury causes are multifactorial. ACL injuries are very treatable. No injury, no treatment, no recovery process are identical. There's a lot of factors to consider about that. Each patient is treated uniquely based on their injury, their activity levels, their goals of what they want to get back to. I tell patients this, I know Chris does as well, that we treat people, not MRIs. And so not every injury needs to be treated the same way. Every patient is unique and their path is going to be unique in the treatment. So some quick points on anatomy. The ACL is the anterior cruciate ligament. This is a thick structure of collagen. It's actually made up of 2 bundles within the knee. And it attaches from the lateral femoral condyle to the anterior portion of the tibia. The size of it lengthwise is very similar person to person, but the diameter and width can change a lot based on patient size. The ACL functions to prevent the knee from moving forward, the tibia from moving forward, and from rotating. And so the other ligaments around the knee help with stability from the posterior translation of the knee, as well as the side-to-side movement. Those are the MCL and the LCL. The medial and the lateral meniscus also play a role in cushion and support of the knee, but also in stability, and they factor into the ACL stability of the knee as well. So biomechanically, the ACL provides about 85% of the stability of the anterior translation of the knee, so the femur moving forward like this. But it also acts as a secondary restraint to rotational instability. And so that's why the ACL, if you look at it on this slide here, in extension, the ACL fibers are taut in one plane. In flexion, they're taut in a different plane. And so that's why it has control, not only moving forward like this, but rotating like that. There's other structures that are important for that stability, and these come into play when we're thinking about someone who has an injury. The medial meniscus is an important secondary stabilizer to the anterior tibial translation. The posterior lateral corner, a complex made up of the lateral collateral ligament, the popliteus, and the popliteal fibular ligament. In the back lateral side of the knee is very important in the rotational stability of the knee. And so if that's injured at the time of an ACL injury, we have to take that into account as well. The ALL is something that's been described more frequently in the last 10 to 15 years, the anterolateral ligament. This is a thickening of the anterolateral capsule of the knee that helps with that rotational control of the knee as well. And then even on the medial side, the MCL and the posterior oblique ligament play a role in this rotational stability. So all of these things are really important in evaluating after a patient has a knee injury to restore the biomechanics correctly. So how do these injuries occur? 70% or more of ACL injuries are non-contact injuries. The tibia gets translated anteriorly while the knee is in slight flexion with a valgus stress applied. And so that's what you're seeing in this picture here. The foot is planted, the knee is shifting and falling into valgus here with a rotational component to it. And that stress on the knee leads to too much stress for the ACL. And that's when you're going to get a tear in these non-contact injuries. This leads to a pivot shift mechanism where as the ACL tears, the tibia basically rotates out and forward and causes a shifting or buckling of the knee. We can also see non-contact injuries in a hyperextension type mechanism, whether that's landing in a hyperextension injury or even on the non-weight bearing kicking leg in soccer injuries, for example. The other type of ACL injury are contact injuries. This is a direct blow, such as the picture in the bottom corner there, someone falling directly onto the leg, usually in this kind of valgus position too. When we're talking about mechanism of injury, it's not super critical once we have an injury to know was that a contact or non-contact injury. Mechanism of injury, I think, is more important though when we're thinking about how do we potentially prevent ACL injuries. With contact sports, especially like lacrosse and football and soccer, you're not going to prevent contact injuries. It's a contact sport, right? If you want to prevent all contact injuries, you've got to stay on the sideline, and none of you want to do that. What we want to try to prevent are these non-contact injuries. Are there ways, are there tools, are there mechanisms, are there things that we can study, analyze, and improve upon to decrease the non-contact injury rates?
So Mark, when you're talking about these kind of rotational injuries, I think it's important to have a sort of decipher, like lacrosse folks are always, especially in the girls game, really quadricep heavy, right? I mean, girls really want to develop their quads and they want to really protect themselves, and they think that's the way to do that. I think in some ways we need to just mention like how important the hamstrings are as we talk about these kind of rotating injuries, as the quad is sort of helping to pull the knee forward, just like the ACL is trying to prevent that. So the quad may actually act against you. And then looking at some of the cleat, sort of discussions around rotational or pivot type injuries as well, just to make a discussion there a little bit.
Yeah, great points. I have a couple things on the next couple of slides that go into those a little bit more detail. So we'll move into that in a second. But definitely things to think about. So Just real quick on injuries that can occur very commonly with an ACL injury. Meniscus tears are super common. In an acute ACL injury, the lateral meniscus can be torn in up to 50% of ACL injuries. Medial meniscus tears are also commonly torn, but that suggests a little bit higher force of injury to get a medial meniscus tear at the time of the acute injury, but it happens frequently. In the chronic ACL setting, where someone's had an ACL tear for a while and has either didn't know it or has chosen not to have a surgical treatment and has gone back to playing, they have a higher prevalence of medial meniscus injuries because that's one of the secondary stabilizers that helps protect the ACL. Other ligament injuries, such as the MCL or the LCL, posterior lateral corner, are definitely very common with ACL injuries as well. Cartilage injuries can also occur with an ACL injury. When that pivot shift happens and the knee rotates like that, the bones impact against each other. The cartilage that's in between there, that it takes that stress, can lead to acute cartilage injuries. You can actually get a piece of that cartilage breaking off at the time of that. Or that can actually, we think and hypothesize, most people who have an ACL injury 15, 20, 30 years later down the road will have arthritic change in the knee. Is there some cellular injury that's happening at the time of the initial injury that's leading to that? So these are all things that we're looking for and thinking about with an ACL injury. So kind of, Chris, getting into some of the points that you were talking about here in the special considerations in the female athlete, 4.5 times higher tear rate in female athletes versus male athletes. And what are some of the reasons for that? One of the main reasons we think is anatomic. And so there is an anatomic difference a lot of times in females to males, where females have a wider pelvis. And so that causes a change in the angle, what we call the Q angle. And so the Q angle measures from the center of the patella up the line of the femur, and then another line from the tibial tubercle up towards the center of the pelvis here. And the wider that angle is, the more of this valgus force or stress is putting on the knee. And the more likely when you're jumping, landing, shifting, that you're going to fall into that valgus position with the knee going inward and the leg going outward. And so that is one of the things that is an anatomic difference between most females and males that we think puts females at a higher risk of knee injury than males. The second part of that is what Chris mentioned before, the quadriceps dominance. Females often have a higher quadricep dominance, and quadricep strength is important for athletes. We want athletes to have a strong quadricep going into that. But if they're too quad dominant, like Chris suggested, that hamstring to quad ratio is important to balance the forces on the knee. And if the quad is trying to pull the knee forward and the ACL is seeing a stress and is getting stressed there while the quad is firing, that can lead to tearing if the hamstrings aren't equally doing their work to control that. Other really important points of that will are core and pelvic stability are really important. So having a strong core, strong hip flexor, strong gluteal muscles to support the hip and keeping the pelvis level during movement, that's important too, because if that pelvis is dropping on that side during activity, that's more likely that knee is going to fall into that valgus position and see too much stress. So it's the balance of all of these things that if they're off, we're going to have a higher rate of the injuries.
I guess take-home point being from that sort of short discussion, particular point being, if you're looking at preventing ACL tears and you're trying to, gear up your pre-season workout, you want to work your core, you want to equally work your hamstring as much as you want to do squats and work on your quads.
Absolutely. It's important to have good control of the leg from the waist down, essentially, right? All of those things need to be balanced from a strength flexibility perspective, and also doing dynamic exercises to work on that neuromuscular control, how to cut, how to jump, how to land. There's a lot of series of exercises that can help to train that, and so that you are not having to think about that, so that those patterns become just fine-tuned muscle memory over time, and that's going to decrease the risk of injury. Just real quick, there's a couple other things that are, considerations in the female population. There have been some studies showing that different phases of the menstrual cycle where estrogen levels are fluctuating and hormones are changing do put people at a slightly higher risk of injury during those time phases. There have been some data and studies showing that females that are on oral contraceptives are not as quite affected by that. This is not a recommendation for all female athletes to be on an oral contraceptive. It is just a, something that has been seen and looked at in the literature. There are also some genetic components to ACL injuries. ACL injuries, if you look at people who have them and ask them about family members, you will find links of families that seem to have a higher rate of ACL injury. And is that due to a connective tissue disorder within that family's genetics, a collagen disorder? Is that due to some other anatomic variants, such as a small intercondylar notch where the ACL lives that predisposes it to impingement during movement? Is that a hypermobility or laxity thing that is prevalent in that family? All of those things can be true. Some of those things can't be changed, right? But the one thing, we have to go back when we're looking at prevention strategies is what are the things we can change? And the things we can change, the number one thing is making sure we're doing the correct training from a neuromuscular standpoint to help decrease the risk of these injuries.
Yeah, one last thing. I know that we talked about this and I didn't see it on your list just for completeness.
Yeah.
Some folks are saying vitamin D deficiency can really play a part in that. There's some new literature supporting that. So just as a FYI, that's out there. I don't think it's as strong as these other factors we talked about, but if you're looking to supplement, that might be something that you can add to your diet that might be easy, or a vitamin supplement that might be easy to help with regards to deficiency there.
Yeah, I think that's a good point. I agree that data is there. It's not super strong in terms of, but there is strong data that the large majority of the population is vitamin D deficient. So that is something that is important, I think, for potentially not only ACL injury strategies, but athletes also who have vitamin D deficiency have been shown to have higher rates of stress fracture. NBA players with vitamin D deficiency have been shown to have higher rates of tibial shaft fractures during the season. So those are, athletes supplementing with vitamin D, I think is a very relatively low risk, low cost, and high benefit. So how do we guide ourselves with prevention? In the ACL world, actually, prevention has been studied a lot, and there's a lot of good resources for it. So these are just two of several programs. These are two that I like and recommend to a lot of my patients and my young athletes. The one on the left-hand side of the screen is the 11 plus, or the FIFA 11 program. This was created by the FIFA soccer organization. And it's a set of initially started as 11 exercises. Now it's a little bit more than that. They've added a few things over the years of basic warm-up exercises that are designed to help improve neuromuscular control, improve core strength, improve glute strength, improve quad and hamstring balance, improve neuromuscular control and stability. And you can see on that list there, they have kind of the warm-up exercises, running, strength, plyometric balance portion, and then some running exercises to finish. And these are exercises that take 15 to 20 minutes to get through once you've gone through them a few times and have some familiarity with it. There's no equipment needed. It's all body weight exercises. And the recommendation of the group was to do them with pretty much every training session. So, at least 3 times a week, but pretty much every practice session. And then there's a shorter version of them before games. And what the studies for that FIFA 11 group found was that in teams that use this in preseason training and then throughout their season as warm up before that, versus teams that did not use it, the teams that used it had an 80% lower ACL injury rate than teams that didn't use it. The one on the right side of the screen is the Prevent Injury Enhanced Performance Program, or the PEP program. This one was developed, oops, I'm clicking the wrong thing. This one was developed out of Santa Monica Orthopedic Group. And again, it's a similar set of exercises, all designed to be completed in a 12 to 15 minute period. That program even comes with a field guide setup. They give a map of a field and say you should do, the warm-up phase here, then they should go to phase 2 here, phase 3 here, and they kind of walk you through the whole thing so that coaches can really have it set up with cones and everything and have it done. And again, their study showed 75 to 80% lower ACL injury rates in teams that utilize their program. And so these are programs that I think, whether it's these two or there's a few others as well, that really every team should be using, whether it's football, lacrosse, soccer, any team that's doing grass or turf related sport type injuries where there's high rates of ACL injuries. These are probably the number one thing that can help decrease that. So then what, kind of is the goal of that, that program is to really correct position when you're going into that quick cut, pivot, or jump land type position so that the pelvis stays level, the hip does not drop, the knee does not go into that valgus force movement. And by doing that, you're really decreasing the stress on the ACL. The ACL is going to fail when you're in a poor position and when the surrounding muscles are working against you. Either they fatigue and put too much stress on the ACL, they're not supporting it well enough because they're not strong enough, or the balance isn't there, so your mechanics and the alignment gets off. And so that's what's going to lead to an injury in those non-contact settings. So learning this program to learn to jump and land like the picture in the middle there and learn to cut like the picture on the right side there is going to decrease that significantly.
I know that you'd mentioned just briefly there about the programs coming up, and I do want to take a little time to just mention, if you haven't in the future, Mark, the opportunity to discuss the artificial turf versus grass phenomenon, right? And I mean, we know that a lot of the higher end teams, when they get to the championship, get to play on the middle field where all there's astroturf or field turf or whatnot, but it's really almost counterproductive in regards to looking at ACL injuries and the type of grass or turf that you might play on.
Yeah, it is a real thing, right? The artificial turf versus natural grass, there are higher rates of lower extremity injuries on artificial turf than there are on grass. The ankle injuries, even higher, especially on the newer surfaces that have come out. There seem to be a higher prevalence of ankle injuries versus the knee injuries. But on the, depending on where you go, you don't know how new that turf is. And so there are several studies in, the NCAA world looking at this, as well as the NFL world. And pretty much all of them show higher rates of lower extremity injuries, whether at ankle or knee. And so that is something that we have to deal with as well. So not only are you working hard to get as much neural control as you can have, but now you've got to flip the field too. And so shoe wear is something that has changed a little bit. These, the difference of cleats, that you should not be wearing the same cleats on your natural grass field as you're wearing on your turf field, because what's going to happen with that is the reason we think this is a problem on these artificial fields is that they don't have as much give as the natural grass may have. And so the high rotational traction or grip between the shoe and the surface, if that's higher, that's going to increase your risk of injury. And so you want your cleat or your foot to catch, right? You don't want it to just slide out from under you when you go to make a cut. That's not helpful either. But if it grips too much and doesn't release, that's when too much torque is going to be applied in that setting. And so the design of, I think, these turf shoes is to have a smaller, more of a rounded nub, not as deep of a cleat, to release sooner during that, still allow you to cut, but release sooner to decrease that torque applied.
Yeah, I'm gonna show you two sets of cleats. Both of these are my daughter's. This is the turf cleat. This is exactly what you're talking about. With these little small nubs in the middle of the shoe versus on the peripheral edge. And then this is the grass cleat, and you can see it's more like blade type. There we go. More blade type, maybe. There we go. Maybe.
more kind of grips into the grass itself. So
Yeah, and so I think that's sorry, the dog's barking in the background, guys. But that's what you can kind of see is that bladed type of a cleat on the edges for the grass. And I think that's in some ways the difference there. And I don't think one versus the other is like, the end of the world. But if you're trying to really think about it, this information really just only came out in the last year or two. And I think companies are trying to push forward some new technology in regards to shoes. So if you only have one shoe versus the other, I know some kids are even switching shoes when it rains on turf to more of the blade type because they slip all over the place. And again, that's not the point of this either. So it's definitely a balance between the two. So I can't say that, for instance, that one would be the only way to go, but it is a little bit of trying to figure out what the best is for the exact time of and conditions of play.
yeah, I think that's a good point. And while these things are coming out and they seem helpful now, you also still have professional athletes all over the world on artificial and grass surfaces getting these injuries, right? And theoretically, they're getting the best advice on which shoes to wear on which days based on which conditions, and you can still get hurt with it. So again, none of these things are making us bulletproof, but we're trying to just bring down our risk as much as possible. And so I think it's definitely a thing to try. I would ask you, Anna, I'm playing on them. How does it feel?
I personally like turf cleats better than regular cleats. I guess it's more of like just a preference than what the cleat like actually does. I
Okay.
mean, but yeah, that's kind of my opinion.
Sure. These were not a something that was around in my era of playing sports, and I'm not going to go out and test them myself. So it's good to hear.
We did have one question about vitamin D dosages in the younger populations for teens. I think what some folks are recommending, and it really depends upon how deficient you might be. So your primary care doctor can, and this is not by any means medical advice, so I don't want anybody to get me in trouble here, but around 5,000 IU is around what you're trying to take over the matter of a week. So sometimes it's about 2,000 of vitamin D3. So if you're picking one, pick vitamin D3 and do 2,000 at least 5 times. So every other day maybe, or you can eat it even every day, as long as you're not overdosing, because it is a fat soluble vitamin. So many people think it's exquisitely safe, and we know that's the case. Up to sort of 50,000 international units. So if you do the math, that's 10 times 5, right? So it's 10 weeks. So, but just as a rule of thumb, 2,000 IU vitamin D3 every day is a good supplement to start with.
Yeah, I think so. If there's anyone that has been tested for it, it's a simple blood test too, and as something that the pediatrician can definitely order and be evaluated, because while that's a very safe dose for most people, there can be people who are extremely deficient and not know it and need a much higher loading dose to get up to safe levels. And so if you're at all worried about it, I think it's very reasonable to ask the pediatrician to be tested for it. And then am I in a range that is, either okay or just slightly low and I can go to that lower dosage, or am I really deficient and need to start with a higher loading dose and then going to that maintenance dose?
Put those sort of brief recs in the chat as well for people.
Sure. And then the other thing, bracing, people ask about prophylactic bracing. Does that help? There's no real support in the literature for prophylactic bracing for ACL for most athletes. The only really prophylactic bracing literature that we have is for offensive linemen, and that helps protect them more from MCL injuries than anything, because these are big guys that are backing up and having people fall on their legs. So for just the cutting sport contact athlete, there's no role for prophylactic bracing.
We had another question about iron supplementation. Iron can be a tough one for supplementation. I know that people typically with diets and, in teenagers, it can be tough to do iron. Around ACL, I don't know of any literature that supports deficiency creating a risk for tear. But iron supplementation, when folks have poor diets, I'm looking at my youngest daughter here when I say that. Being an issue. So I don't think it's a bad idea to supplement, but it can be intolerable from a GI side effect that can create constipation and stuff like that.
For sure. I do not think it has, I don't know of any literature to it on ACL and musculoskeletal injuries themselves, but that's definitely one to discuss with the pediatrician if you are concerned about your child being iron deficient, because like Chris said, it can definitely be a difficult and not well tolerated supplement if not taken correctly. So any other questions or things you want to talk, Chris, about with type of injury prevention before we move into the next phase of what happens when we have one of these?
I got another question that said I'm recovering 11 months from an ACL injury. Thoughts on bracing post ACL recovery? Maybe you want to answer that, Mark.
Sure. So I am not a strong believer or user of post ACL braces for recovery and return to play. I think if you look at the literature on that, the literature supporting use of braces is pretty weak, and there's really not good evidence to show that use of an ACL brace post-operatively reduces re-tear rate, and that's what people are trying to do, right? Is reduce re-tear rate. So looking at it from that perspective, it's not super helpful. Now, does that mean that I never send anyone back to playing in a brace? No, sometimes there are factors that play into that. And so I'd say there's really three people that I send back to playing in a brace. One, they or a family member of theirs previously tore an ACL and returned to play in a brace, and they have been told from day one that they will be returning in a brace. It is in that person's head. It is in that family member's head. It is in their mind that they need a brace to go back to play. And so they go back to play in a brace until they get to the point that they're sick of it and they feel like it's limiting them. And then they get rid of the brace. Two, they have a physical therapist who at 3-4 months out tells them, when are you getting your brace? You need this before we can go to the next level of therapy. And then the same thing. It's more of they're getting it because it's been told to them that they need it. The only time that I will prescribe a brace to someone other than those two and where I feel that they need it is in the athlete trying to go back who is physically ready, but not mentally ready. And they are anxious about return to play. They are further along than they think they are. And myself, their parent, their physical therapist, someone has brought it to my attention too, that they feel like this is more of a mental hurdle now than it is a physical hurdle, which is true. There is a big component of mental recovery to getting back onto the field. And so sometimes we use a brace in that regard to provide confidence. And so that person has great strength. They're passing all of the tests that we're putting them through in physical therapy, but they just don't feel confident and ready. And so if you ask them to do stuff or if they want to try doing more, they don't. And so sometimes getting that person a brace gives them that confidence. Just having something on their knee, that that touch to their knee, that compression, that feel that they get reminds their brain that something is there protecting them, and they then go out and do it. And again, those people I think don't often play in a brace for very long.
So I mean,
chime in there just as it relates to the college recruiting process. I just want to reemphasize Mark's answers here. I found the brace to be largely psychological, and a coach will never tell you to not wear your brace because we're kind of assuming that the doctors are working with you on that piece of it. I just want to share anecdotally, a college coach recruiting players has a really hard time. They also have a hard time psychologically getting past the brace. So sometimes in the recruiting process, it almost continues to delay the return to confidence, because your recruiting process might be delayed, just because a coach might overlook you because you're wearing a brace, and it's psychological for them as well. They think you've lost a step, or they think, you're not back 100%. So if it's not necessary and you're mentally there, I'm just a big fan of, coming back without the brace, but we will never say that to a player if they're coming to a field with the brace. So because of that psychological piece, but I appreciate you kind of affirming that, Mark, because I've noticed then it just makes it almost worse because the kid's recruiting process becomes harder, more unnecessarily, when it might be more of a fitness issue, or like like they're still getting their speed back, but the brace sometimes just makes it look more delayed than it is.
Yeah,
I think
I think that's a good point. And sorry, Chris. I think the other part of it is too that historically that answer was different, right? Like 15, 20 years ago, everyone went back in a brace. Not forever, but usually it was. And when I finished training in residency, at least, that was like the test answer, that people went back to playing in a brace for their first year, and then they could potentially wean away from it. But more and more and more, the data is showing that's really not necessary, and it's not really improving anything. And so, if we're doing something, we want it to benefit. If it's going to reduce re-tear rate, yeah, put people in a brace, just like the offensive linemen wear a brace, because that's actually been shown to protect them from MCL injuries. For people going back after ACL injury, it's not necessarily the case, but does that mean that you don't have someone like Tom Brady who went back wearing his ACL brace and wore it for the rest of his career? No, I mean, so it's definitely something that people can still play in and be functional in. And so I think most of the time when you're seeing other people in it, it's a lot of times not necessarily that person needs it or feels the confidence or lacks the confidence that they need it. It's that they've been told or it's been prescribed by the physician, or they've been told that's what we do. And there's still lots of physicians that do that. I don't think they're necessarily wrong. I just don't think it's necessary.
Well,
So,
I think we should just flash to Tom Brady's combine video of his sprinting as well, and that might help to support not wearing a brace.
yeah.
But nonetheless,
Well,
so two things.
also his
Two
sprint
things.
20 some years later was improved because he actually and doing more of the neuromuscular training.
Two things to bring up. One, that question being, would you recommend a compression sleeve when recovering from an ACL or an MCL injury? I want you to answer that first, and then when you're done with that, I really do want to put a fair bit of time towards the discussion around the psychology of tearing your ACL traumatically, getting ready to play, and in some of the experience we have in that regard. So if you can answer that question first, and then maybe we can lean on that psychology discussion a little bit.
Sure. So is this the question about the compression sleeve, is this like an acute MCL sprain use of a compression sleeve, or is this like an ACL tear and we're post surgery and we're using a compression sleeve there? Which do you want me to talk about, or both?
Maybe
Quickly,
both.
both.
It was an anonymous question from
All right.
someone that was attending. Yeah.
So say you have a MCL sprain alone, a grade 1, grade 2 MCL sprain, which we can treat non-operatively majority of the time. Use of a brace or compression sleeve in the early phase of that recovery, I think is helpful and important. If we can get the effusion down, we get the swelling down, provide a little bit of stability there. And then through therapy, rehabbing the quad, getting the function and firing of that muscle back, that compression sleeve sometimes can help by not keeping that effusion down, but then also reminding the brain that something is there and to use that quadricep while you're redeveloping that neuromuscular control. From an ACL perspective, I'd say the similar thing goes, post ACL surgery, people are going to use a post-operative brace usually for anywhere from 2 to 6 weeks, depending on their surgery and what concomitant injuries they had with it. But usually by 6 weeks, most people are weaning out of that post-operative brace and really not needing to use a brace. If that person, as they're starting to amp up their rehab, is starting to get swelling in the knee, which is very common during recovery, a compression sleeve may help with a way to decrease some of that swelling, which helps to get the quad control back. When the knee swells, it shuts down the quadricep muscle. If you can't regain the quadricep muscle functioning and firing well, you're not going to progress to the next levels of your rehab, and you're not going to get back. And so using whatever tools and strategies we have with icing, compression, anti-inflammatories, things to keep that swelling down during the recovery process is helpful.
Yeah, I agreed. And I think that's a good answer. When we look to transition the discussion towards the psychology component of it, I think that weighs a little bit there to say, the thing that we want people to understand is that your knee is going to be recovered, right? In some ways stronger than it was before, or maybe the other side, given the new technology that we have with these fertilized ACLs and things of the sort. So I guess going to time of injury, folks can get very disappointed, can get very, they feel like their life is over, whether it be in the middle of a recruiting process or just coming into it. And I think just to speak to that a little bit, to say, like, I think it's terrifically important, tremendously important to have words of encouragement from your teammates, from your coaches. Lots of people get into college and play at a very high level, even with ACL injuries. I don't think it's nearly the death sentence even that it was 10 years ago. I mean, it's almost in some ways a little bit, unfortunately, of routine for coaches to understand that that's going to happen. And I think you use that as an opportunity as a player to say, hey, I'm committed to getting better. And it gives a little insight into what kind of a personality that person has and what kind of a worker they are, to show that, and I think we've had lots of patients that have come from lacrosse to use that as an opportunity to say, yeah, I'm not at the showcase, but look at how much I'm working, right? And posting that on their social media and working with you to do some of the educational stuff that is on our websites, Mark. So I just wanted you to kind of speak a little bit to that.
Yeah, I mean, this can be, at the time that it happens for people, a devastating injury, especially teenage or early collegiate athlete who may never have gotten hurt before, or this may be the most significant thing that's happened in their life, right? What I want to tell that person when I first meet them is that, okay, you hurt your knee, but I'm not telling you today that you have cancer. You will not die from this problem. This is a recoverable injury and recoverable problem that lots of people get through. And I don't say that to minimize it. I say that to just put a little perspective on it, that while this is a bad injury and this may be the worst thing that has happened to you, this is a very recoverable injury. This is something that we can get back from. This is not something that is going to end your sports career. That is not something that is going to, you can still have an extremely productive, successful life and even an athletic career with this. So putting a little bit of perspective on that, changing that mindset of devastation to hope, right? And so that's, I think the earlier we can do that, the better. And so I think that whether it's, myself doing that at their first visit I have with them, whether it's the coach who has some experience with this doing that at the sideline at the time of the field, whether it's another teammate or friend or former teammate who's gone through this process, someone reaching out in that regard to let them know it's going to be okay, I think early is super helpful. The other thing that I think is really helpful in that process is early rehab and therapy, even prior to surgery. So starting them with a therapist immediately to show some exercises that you can start doing right away that aren't going to hurt your knee, that are actually going to help prepare you for surgery and help prepare you for later. And so that even within a few weeks after the injury, before you have surgery, you may have no swelling, your quad may be firing again, and you may have almost full range of motion of your knee. And so then you can say, as people start to think, even with my ACL torn and not fixed yet, look what I can do. So I think that the whole way along, it's, you can't, there's not going to be a limit on you. We're going to get you through this so you can do everything. You can't do everything right now, but later you will be able to. The second phase of that comes into after surgery, and the first part after surgery is pain, swelling, recovery, like that's there, that's real, that happens. But that goes by pretty quickly and people come out of that quickly. Where people start to slow down then is 3, 4, 5 months out, when we start to push them a little bit more. There's different reasons why people, I think, will struggle. One is they push a little bit more, and their knee had done really well throughout the whole recovery. And then we get to a point where we say, okay, now it's time to start jogging, or now it's time to start doing this. And that little push a little bit more causes their knee to swell. They hurt, they actually drop back down. They get more pain. They think that something's wrong, right? And sometimes people will struggle through that phase. Or people are doing so well that they start getting frustrated that they can't do more, because we're telling them we have to go a little slower because of some of the biology of healing. Not that we're going slower because we want to keep them out. We just need that ligament, graft, everything to heal correctly so it's safe to go back. And so just constant reassurance through that process from everyone is really helpful. The rehab after a knee injury is not a linear line to success. No one starts here and ends up here just like that. The rehab process looks like this. There's ups and downs the whole way as you climb that ladder till you get back to the top.
Yeah. I mean, I guess the other thing I would say is it's really helpful from the team perspective to not isolate that person, right? If you reach out as a teammate to that person, from the doctor side of it, just having patients gone through it, it's really impactful to understand how much just a note from another teammate makes to that person who's injured. It is very, very impactful. So I'd say to all of those folks out there that are listening, just if you do know somebody that is going through it, just hey, we're looking to say hello and encourage you, and can't wait to see you back there. It's really helpful.
Yeah. I encourage all of my athletes going through this to be a part of their team. When it's safe, to get back out on the sidelines, to go to practice, to go, just there as a support system, wear your jersey, be a part of, you're still part of the team, right? You're hurt right now, but you're still there. You still can have that camaraderie and joy in the team's success, and, help contribute from the sideline. Tell your teammates what they're doing wrong, things that you see that they didn't see, right? So being a part of it helps them to have some hope about going back to it.
I guess maybe as a last sort of few minutes here, we can go through, at least hopping ahead to ACL reconstruction. While you're doing that, Mark, you can talk about fertilized ACL and that procedure, just because it's so new and people might not have heard about that yet before.
Yeah.
And
Jump
in
through
the
some of these slides on, MRI findings, big effusion, disruption of ACL fibers. This is where we look for other injuries. Treatment options, non-operative, I won't even get into because that's not an option in this age category and athletic endeavor. Operative wise, ACL repair is a technique that is out there. It is a very small subset of types of ACL tears that are candidates for repair. So we're going to focus on reconstruction, which is really the gold standard. From a graft choice perspective, autograft is the way to go. Autograft means taking a graft from that person, from you, to make the new ACL. And the choices we have from that are bone, patellar tendon bone, or BTB, quadricep tendon with or without bone, hamstring tendons, and then allograft tendons or cadaver. In this age group athlete, I don't consider that an option. There's 5 times higher re-tear rates with cadaver tendons. Sometimes in older people will use that, or someone's had multiple ACLs and we don't have a tendon left and have to use a cadaver. But in the young athlete with a 5 times higher re-tear rate, cadaver is not an option, in my opinion. So what is my technique then for this? So over the last 9 years that I've been in practice, I've changed and honed and done a lot of different things. I've done all of those types of grafts, and for a multitude of reasons of going through them, this is where I've kind of settled my practice now in terms of my favorite technique for doing ACLs. In terms of the surgical success, the surgical speed, the recovery that I see in the patients, and the return to sport that I'm seeing in them, that makes it my choice now. So we use the quadricep tendon from the patient, and we use that to create a new graft. It's not the whole tendon. It's a portion of the tendon, 9 to 10 millimeter diameter, about 70 millimeters in length. We harvest that through an incision that's really 3 to 4 centimeters from the top of the kneecap up. And we take that tendon and we make it into the new ACL. We use an internal brace or a suture that is fixed as kind of an augmentation. So the suture is attached to the femoral point of fixation where it's fixed there. And this will make sense more in a second when I show some pictures. And then it's attached to a second point of fixation on the tibia that's separate from the fixation of the graft. So that is kind of acting like a seat belt to help protect the graft while it's healing and help hold some of the tension on it. And we're seeing better biomechanical results, not only in the lab, but also clinically with use of the internal brace. And then this idea of biologic enhancement. So I can't take credit for this. My friend Chad Lavender up at Marshall University in West Virginia really developed this technique of the lavender fertilized ACL, he called it, or some other people call it a bio ACL, but it's really trying to use biology to help healing. So we're trying to optimize position of the ACL, putting it in the reconstructing it in the right anatomic position, improving the mechanics of it by using certain types of fixation and an internal brace as kind of a check rein or seat belt on it, and then trying to enhance the biologic healing of it too. All of these things to try to get a stronger, better graft so that ultimately we can get people back to sport and decrease the risk of re-injury. So what do we do here for this fertilized technique? So we start with doing the harvest of bone marrow from the tibia. So at the time of surgery, once the patient's asleep, we actually put this needle into the bone through one of the incisions we'll use for the ACL reconstruction, and we harvest about 60 cc's of bone marrow from that. That is then taken to a centrifuge and spun down to concentrate it to create bone marrow aspirate concentrate, which is then taken and mixed with a allograft bone or a cadaver bone graft material. This is a demineralized bone matrix that helps augment tissue healing. We use it in fracture surgery when we're trying to get bone to heal the bone. And then when we drill tunnels for the ACL here, we also can collect that graft. We mix that all together and then load it into this syringe with this delivery cannula that then those tunnels where we are going to be putting the ACL, before we put the ACL in, we fill those tunnels with that material. And the goal of that is to help that collagen heal to the bone so that it heals just like your native ACL was. So here's some videos of this technique. So this is in the knee after we have drilled the femoral tunnel. And this is passing the sutures. We use this suspensory fixation where this button that you'll see here in a second as I pull it back out, this button goes through a small hole on the end of the tunnel and then basically flips onto the cortex of the bone. And once it flips here in a second, there, it just flipped. Now I'm pulling back on those sutures and that's firmly attached there. And so that button's not going to go anywhere and the ACL is attached to these sutures there. And so then in this next video, before we pull the graft into the tunnels, we take that delivery tube and we place it into the tunnel. And then you're going to see here in a second, this is where we're going to inject that fertilized putty, I call it, the mix of the bone graft with the bone marrow aspirate concentrate. This fertilized putty, we're going to fill that tunnel with. Then just jumping ahead, we fill that femoral tunnel. And then we kind of reposition and fill the tibial tunnel there as well. And so at the end of that, we have both tunnels full of that bone graft material before we bring our new ACL in. Oops, I went one too far. So then this is as we then start pulling on those sutures, we'll pull the graft into the femoral tunnel. You'll see it coming up here in a second. So there goes the graft into the femoral tunnel and it docks in place there. And I'll jump ahead because I know we're on time there. And then once it's seated in the femoral tunnel, then we pull it through sutures down into the tibial tunnel. And there's the ACL fixed in place. So then on the tibial side, we take the scope out and we tighten it up and fix it there. And so then you can see here's our completed graft. It's nice and stable and strong. And as we take the knee through range of motion, out into extension, the graft doesn't impinge. And this is just looking at it from the other side there. So you can see the sockets really filled in nicely with the bone and the graft. So that's going to heal really well. So why fertilize? Why do this biologic enhancement? So a couple reasons: improving blood flow at the ends of those femoral tunnels, trying to get that tissue to heal to the bone, trying to help promote ligamentization of the ACL graft. So what happens over time is we want blood vessels to grow in and around that ACL to make it your own tissue. And so if we can get that to heal to the bone faster, if we can get that process to happen faster, we're going to hopefully get a better, well-incorporated graft. We're seeing patients passing dynamic testing quicker with this. We're seeing less pain post-operatively. We're seeing lower re-tear rates. And so for me, this has really become the standard in my practice now, is recommending this as I've just seen so much better improvements. My friend Chad Lavender up at Marshall has done a couple of studies on this over the last few years. And most importantly, in his most recent phase 2 study, was a 2-year randomized control trial. And what he found was that pain scores, functional improvement scores, strength testing were all better in this fertilized ACL group compared to the non-fertilized group at 6-week, 12-week, and 6 months. By a year, they were still slightly better, but not statistically better. By 2 years, the groups had really kind of equalized in terms of their functional results. So the question is, does this earlier improvement matter if at the 2-year mark they're similar? I would argue yes, it does, because that early time period is when people are rehabbing to get back to sport. Do we want it to take them 2 years to do that and feel confident and comfortable that they can go back safer and that they're passing those things? If they're passing these tests sooner, feeling better sooner, we can start pushing them in therapy more. They're getting confidence back sooner. They're hopefully going to translate that to more confidence when they return to play. So case example, this is at 12 weeks with one of the fertilized grafts. What you see on x-ray is really this femoral tunnel, especially the tibial one, is starting to heal in, but the femoral one, you almost don't see the socket at all, which Chris will tell you, normally at 12 weeks without that fertilized material, you still see those full sockets there.
I think this kind of just reinforces the fact that this is, a better technique, and it's encouraging for young athletes who do have ACL tears, clearly to understand that there's a lot of tremendous innovation that can put them ahead of the game. And I know we're cutting close on time. If anybody has any questions they want to speak up right now, maybe Mark and I can answer them before we close this out. And before we do that, I just want to say, Teresa, I'll put my email in the chat. If anybody has questions they want to email me directly, or has a person that has a tear that they want to talk about a course with me, I'm happy to educate them through that process if that's necessary for anybody, unfortunately.
Same. I'm happy to help with that too. This last slide here just really shows a case example. We got an MRI on someone 7 months out from this, and the ACL looks completely normal on MRI, and this person had a little scar tissue in their knee that we had to go back and clean out. But at the time of second look arthroscopy, it looks like a totally native ACL. So really happy with that. So thank you guys. Appreciate it.
Someone was asking about the 11 plus dynamics in Team Snap. We can definitely put that in there. And then everyone who was a part of our program in the fall should have copies of what we call the pre-activity prep, which is really similar. Some of it's taken, it's a few more steps than the 11. But I can actually post both in Team Snap. And that's just one thing I would say is we're always kind of giving you the tools to get the reps on your own and for you to do on your own. The few times that we're together with our national teams certainly is not going to prevent much. So it's really important to commit to these kinds of things on your own. So I think all the girls at the fall Pursuit of Better Academies would have pasted the pre-activity prep in their books. I think at the summer team camp, we did it this past summer. So we'll reissue those tools, and we'll send out the recording of this Yeah, I just want to thank you guys for taking the time. This is awesome.
Of course, thank you. Yeah, no, I would just echo that, Teresa, that doing those exercises 3 to 4 days a week, especially the way your club's set up with people being all over the place. You girls
Yeah.
and have to be on it that this is happening 3 to 4 days a week. That's going to help a lot.
Get out to your rec practices, get out to your high school practices early to do it, because it's pretty hit or miss if those programs are going to take the time. They might have 90 minutes that they get on the field scheduled, so you may have to do it on your own. But that's kind of what Tenacity is all about, figuring out what you need to do for your body and for your mind.
Great.
Awesome.
Yep. Thank you very much.
All right.
Appreciate
Well,
it.
thanks, you guys. Everybody have a great night.
Thanks, you too.
Take care.